Dear students, the remaining drugs from the urinary tract anti-infective agents we are going to study in details. First drug, that is the ciprofloxacin. What is the ciprofloxacin? You can see the nomenclature: 1 cyclopropyl, 6 fluoro, 1 4 dihydro, 4 oxo, 7 1 piperazine, 3 quinoline carboxylic acid. Now you can correlate this IUPAC nomenclature with structure. 1 cyclopropyl, you can see here over here 1 cyclopropyl, 6 fluoro, 1 4 dihydro, 4 oxo, 7 piperazine, 3 quinoline, this derivative is quinoline, 3 quinoline carboxylic acid. It is supplied in both oral as well as parenteral dosage form. The hydrochloride salt of ciprofloxacin is available in 250, 500 and 750 mg tablets for the oral administration. Intravenous solution, that is for the parenteral use, it containing 200 mg and 400 mg are provided in concentration of 0.2% in normal saline solution and 1% in 5% dextrose solution. The bioavailability of ciprofloxacin following oral administration is good, with 70 to 80% of on oral dose being absorbed. Food delays but does not prevent absorption. Significant amount, that is 20 to 35% of orally administered ciprofloxacin are excreted in the feces, in part because of biliary excretion. Biotransformation to less active metabolite accounts for about 15% of the administered drug. Approximately 40 to 50% of unchanged ciprofloxacin is excreted in urine following oral administration. This value increases to 50 to 70% when the drug is injected intravenously. Somewhat paradoxically, the eliminates half-life of ciprofloxacin is shorter following oral administration. That half-life is 4 hours. Then it is following intravenous administration, that half-life is 5 to 6 hours. Ciprofloxacin inhibits the P450 species, that is CYP1A2. The oral dose of this quinolone, that is ciprofloxacin, is typically 25% higher than the parenteral dose for the given indication. Probenecid significantly reduces the renal clearance of ciprofloxacin, presumably by inhibiting the active tubular secretion. Ciprofloxacin is widely distributed to virtually all parts of the body, including cerebrospinal fluid, and it is generally considered to provide the best distribution of the currently marketed quinolones. This property, together with the potency and broad antibacterial spectrum of ciprofloxacin, accounts for the numerous therapeutic indications for the drug. It also exhibits higher potency against most gram-negative bacterial species, including P. originosa, than other quinolones. Ciprofloxacin is an agent of choice for the treatment of bacterial gastroenteritis caused by gram-negative bacilli such as enter pathogenic E. coli, Salmonella species, including various Salmonella typhi, Shigella species, Vibrio species, and Aeromonas hydrophilia. It is widely used for the treatment of respiratory tract infection, and it is particularly effective for controlling bronchitis, pneumonia caused by gram-negative bacteria. Ciprofloxacin also used for combating infection of skin, soft tissues, bones, and joints. Both uncomplicated and complicated urinary tract infection caused by gram-negative bacteria can be treated effectively with ciprofloxacin. It is particularly useful for the control of chronic infection characterized by renal tissue involvement. The drug also has important application in controlling venereal diseases. A combination of ciprofloxacin with cephalosporin antibiotics, that is ceftriaxone, is recommended as a treatment of choice for the Disseminated gonorrhea, whereas a single dose treatment with ciprofloxacin plus doxycycline, a tetracycline antibiotic, can usually eradicate gonorrheal urethritis. Ciprofloxacin has also been used for chancroid. The drug has been approved for the post-exposure treatment in inhalational anthrax. Our next drug is Ofloxacin. It is the 9-fluoro-2,3-dihydro 3-methyl 10-4-methyl 1-piperazine 7-oxo 7-pyridino 1,2,3-D 1,4-benzoxazine 6-carboxylic acid. It is a member of quinolone class of antibacterial drugs wherein the 1 and 8 positions are joined to form a 1,4-oxazine ring. You can see this ring in the structure. Ofloxacin resembles ciprofloxacin in its antibacterial spectrum and potency. Like ciprofloxacin, this quinolone is widely distributed into the most body fluids and tissues. In fact, higher concentration of ofloxacins are achieved in cerebrospinal fluid than can be obtained with ciprofloxacin. The oral bioavailability of ofloxacin is superior, that is 95 to 100%, to that of ciprofloxacin, and metabolism is negligible. The amount of an administered dose of ciprofloxacin excreted in urine in a 24 to 48 hour period ranges from 70 to 90%. There is relatively little biliary excretion of these quinolones, although food can slow the oral absorption of ofloxacin. Blood levels following oral and intravenous administration are comparable. The elimination half-life of ofloxacin ranges from 4.5 to 7 hours. Ofloxacin has been approved for the treatment of infections of the lower respiratory tract, including chronic bronchitis and pneumonia caused by gram-negative bacilli. It is also used for the treatment of pelvic inflammatory diseases and is highly active against both gonorrhea and chlamydia. It is common with other fluoroquinolones. Ofloxacin is not effective in the treatment of syphilis. A single 400 mg oral dose of ofloxacin in combination with the tetracycline antibiotics doxycycline is recommended by the Center for Disease Control and Prevention, that is CDC, for the outpatient treatment of acute gonococcal urethritis. Ofloxacin is also used for the treatment of urinary tract infection caused by gram-negative bacilli and for the prostatitis caused by E. coli. Infection of the skin and soft tissue caused by staphylococci, streptococci and gram-negative bacilli may also be treated with ofloxacin. Next drug is Lomefloxacin. The IUPAC nomenclature for Lomefloxacin is 1-ethyl 6,8-difluoro 1,4-dihydro 7,3-methyl 1-piperazine 4-oxo 3-quinoline carboxylic acid. It is a difluorinated quinolines with a longer elimination half-life, that is 7 to 8 hours, than other members of this class. It is only quinoline for which once daily oral dosing is sufficient. The oral bioavailability of Lomefloxacin is estimated to be 95 to 98%. Food slows but does not prevent its oral absorption. The extent of biotransformation of Lomefloxacin is only about 5%, and a high concentration of unchanged drug ranging from 60 to 80% are excreted in the urine. The comparatively long half-life of Lomefloxacin is apparently because of its extent tissue distribution and renal reabsorption, and not because of plasma protein binding or enterohepatic recycling. Lomefloxacin has been approved for the two primary indications. The first It is indicated for acute bacterial exacerbation of chronic bronchitis caused by H. influenza or Moraxella, etc., but not if Staphylococcus pneumonia is causative organism. And second, it is used for the prophylaxis of infection following transurethral surgery. Lomefloxacin also finds application in the treatment of acute cystitis and chronic urinary tract infection caused by gram-negative bacilli. Lomefloxacin reportedly causes the highest incidence of phototoxicity, that is photosensitivity, of the currently available quinolones. The presence of halogen atom fluorine in this class at the 8th position has been correlated with an increased chance of phototoxicity in the quinolones. Next drug is Sparfloxacin. Sparfloxacin is cis-5-amino 1-cyclopropyl 7,3,5-dimethyl 1-piperazine 6,8-difluoro 1,4-dihydro 4-oxo 3-quinoline carboxylic acid. It is a newer fluoroquinolines. This compound exhibit higher potency against gram-positive bacteria, especially Staphylococci and Streptococci, than the fluoroquinolines currently marketed. It is also more active against chlamydia and the anaerobe bacteriocytes fragilis. The activity of Sparfloxacin against gram-negative bacteria is also very impressive, and it is compares favorably with Ciprofloxacin and Ofloxacin in potency against Mycoplasma species, Legionella species, Mycobacteria species, and Listeria monocytogenes. Sparfloxacin has a long elimination half-life of 18 hours, which permits once a day dosing for the indication. The drug is widely distributed into the most fluids and tissues. The effective concentrations of the Sparfloxacins are achieved for the treatment of skin and soft tissue infection, lower respiratory infection including bronchitis and bacterial pneumonias, and pelvic inflammatory diseases caused by gonorrhea and chlamydia. Sparfloxacin has also been recommended for the treatment of bacterial gastroenteritis and cholecystitis. The oral bioavailability of Sparfloxacin is claimed to be good and sufficient. Unchanged drug is excreted to be effective for the treatment of urinary tract infection. Nearly 20% of an orally administered dose is excreted as an active glucuronides. Dear students, here we complete the quinolones derivative. In next session, we are going to study the nitrofuran derivatives. See you.